My name is Elías Eyþórsson. I'm internal medicine resident at the University Hospital of Iceland, and I'm also a postdoctoral research fellow at iStopMM project, and I've been working with the iStopMM team, mostly looking at statistical models for use in patient-physician decision making. And what we've been working on recently is a predictive model, a clinical calculator of sorts, which is meant to inform the decision on whether to obtain a bone marrow sample in upfront workup of newly diagnosed MGUS. And so MGUS is this paraprotein, I suppose, condition, or where there's a measurable paraprotein that's not causing any symptoms, and this is can be said a pre-state to some further problems that may come down the line. And there are several fairly unique problems that have to do with this being very common. So the older the population gets, the more common it gets, but this is a substantial proportion of people just walking around in their day-to-day lives. Another kind of unique aspect is that most of these individuals will never have any disease resulting from this. And so following these patients up presents a problem, because you don't want to follow up patients intensively, you don't want to make them come too often, and you don't want to do invasive testing. Having said this, there are some tests that are very useful in certain populations, certain percentages of the people that have MGUS. And what I'm referring to now is specifically bone marrow biopsy. This is obviously a very safe procedure, but it can cause pain, does mean that you need to see your physician. It takes some time, and because this is such a common condition, it's unreasonable to biopsy everyone, and you wouldn't want to do that. So what we decided to do is leverage this unique data set that we have. We have roughly 2,500 individuals with MGUS who were randomized to a protocolized follow-up. So there was no hidden factors that influenced the decision to obtain this bone marrow biopsy. It was decided beforehand as part of the procedure. And so there's no bias involved in any of the treatment factors that we know about the patient influencing the decision to obtain the bone marrow biopsy. It's an unbiased relationship. And we used information that had previously been reported in the literature. We knew there are certain relationships that we would suspect could predict whether the bone marrow is abnormal. We developed a multivariable prediction model to predict whether the test results would be abnormal. That's what you want to know. If there's an extremely low probability that the test result would be abnormal and therefore change the treatment or change the follow-up, then it could be very reasonably argued that this can be avoided, at least for now, avoiding these specific visits for this purpose, avoiding the pain that can follow from this invasive testing. But furthermore, because it's a probability that comes out of this, this facilitates a physician-patient shared decision-making. The physician can inform the patient what the probability is and discuss what this means, and then they can come to a decision together. And of course, the community can decide what thresholds of low risk are acceptable. And what we found is that we can predict this very well based on very common blood test results that are used in the general workup of MGUS anyway. And we showed that using this model outperforms other common ways of informing this decision. And then we would throw the ball back to the community to decide how they're going to use this and whether they can come to a consensus of what is considered a low risk threshold. So that's kind of what we've been doing.